Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami. Welcome to our Monday Instagram chat. Today we're going to have a little bit of an open forum, and as such, anybody who has some questions, to please just text your questions, and I'll be happy to answer any specific questions. The whole idea is to have 20 minutes of answering what's important to you guys. But the first question anybody usually asks when they come to the fertility doctor is, basically, if we've been trying to get pregnant, what are we doing wrong? How do we figure out what to do? And just to make things simple, when we're looking at fertility in a couple, there can be male factors or female factors or a combination of factors that affect fertility, and sometimes it's unexplained totally. So for us to be good at what we're doing, which is to get you guys pregnant, it's important for us to understand what the cause of the infertility is, even if the cause of that is unexplained. So we can have a male factor, a female factor, an unexplained factor, or a combination of things. And on the female side, the three basic questions are: do I ovulate? We can answer that by looking at temperature charts or ovulation predictor kits or blood tests in the second half of the cycle. The second question is, do I make good eggs? We can answer that question by assessing ovarian reserve, correlating that with age, antral follicle count, and ovarian volume at the very beginning of the cycle, and some blood tests called FSH, estrogen, and AMH level. And thirdly is the anatomy work. My tubes open and the uterus normal, and in that situation, we usually use a hysterosalpingogram, where they can inject some dye into the cervix and take a fluoroscopy picture, an X-ray basically of the uterus and the tubes that will confirm that the tubes are indeed open and the cavity is uterus is normal. And that gives us a general idea of what's going on the female side. On the male side, it's a little simpler. We just get a sperm sample. It's important to collect that within 2 to 3 days of the last time you had relations. And we look at the count, motility, and morphology to assess whether the sperm is good or not. When we put all those things together, we can assess what the cause of infertility might be and how to go about treating each individual cause. First question today is, does plasminogen activator inhibitor, otherwise known as PAA-1, play a crucial role in fibrinolysis and implantation? So the question really is, what are the things that causes embryos not to implant successfully? And the single most reason why embryos don't work is that they're not normal embryos. And what I mean by not normal embryos is they can look terrific under the microscope, they can grow at the right rate, and this can happen whether they're growing in the petri dish for IVF or they're growing in your tube and then uterus before they implant. But the blastocyst embryo, which looks like a little soccer ball on the 5th or 6th day of development, implants beginning about the 7th day, and the embryo will try and implant. The biggest reason why it doesn't is that the embryo itself isn't normal. And if you look at patients who miscarriage, you see that in that about 50% of embryos that miscarry after implantation are abnormal. And we know furthermore from IVF that if embryos are not normal, they're not going to work. So it's very beneficial to do what's called pre-implantation genetic testing to make sure embryos are normal genetically before we put them in. The second part, more related to the question, is what host factors may play a role. In other words, if we put a normal embryo in, or what we think is a normal embryo because it has the right number of chromosomes, there may be other factors that we don't have a good handle of why a normal appearing embryo that has the correct number of chromosomes still doesn't stick. That could be embryo based, but we don't know what to measure. But if we look at the things in the host that can play a role, on the female side, there are factors such as anatomic variants of the uterus. There could be congenital abnormality of the uterus. It could be scarring in the uterus, fibroids in the uterus. It can be inflammation and chronic endometritis that can prevent an embryo from sticking. There can be immunologic factors, such as an elevation in what are called natural killer cells that normally work in your behalf to police the bloodstream and look for funky cells and get rid of them, and they're recognizing an embryo as not being normal, so your immune system is trying to reject it. There can be antiphospholipid antibodies, which react the same way to fetal cells and cause the embryo to not stick. And lastly, a little more controversial, is whether clotting disorders in the microcirculation will predispose to miscarriage. And one of the tests, there are about 10 or 12 different tests of the clotting cascade, of which one of them is plasminogen activator inhibitor. And if that's abnormal, then it may or may not play a role. So if you have an abnormal clotting cascade, we usually have you see a hematologist. Sometimes it's significant and sometimes it's not. If it's in concert with other things being abnormal, it may play more of a role. So it's a matter of the history at hand. And the last part of implantation is whether we've got the window properly. In other words, we have you on estrogen and progesterone to sequence the timing of an embryo to be put back in the uterus, and are we hitting a home run there? Are we missing it somehow? And although it's still a controversial test, there is a biopsy that can be done at the time of implantation, and we can send that for special testing called an endometrial receptivity assay, and that looks at which genes and proteins are being expressed at the time of implantation relative to the amount of progesterone exposure of the lining. And whereas most people would have a predictable response, and we can identify for most patients the best 12-hour window to put an embryo in, sometimes patients may have, particularly patients with multiple failed cycles of implantation of normal embryos. In that subgroup, this test may be of value, and it may tell us that, okay, despite us doing everything right, despite doing everything right, your particular lining isn't responding in a normal time frame. So that when we think the endometrium is where it is, it may actually be 12 or 24 hours off from that. So we can change the timing of embryo transfer, change the timing of embryo transfer to coordinate with what genes are being expressed. Sometimes it makes a difference and sometimes not. Question of natural killer cells, how do we measure them? We measure them in blood. There's no commercial way to measure these in the lining of the uterus that I'm aware of. So we usually do a blood test on the mother, and if it's elevated, they always do a in vitro suppression to see whether it suppresses with intralipids, which is what we would use to treat that. With ovulation induction, question is, what dose do we recommend for a 39-year-old with no ovulation issues? Using fertility drug and IUI is a good first step if the tubes are open and you've got unexplained infertility. Pregnancy rates are not going to be super high, but they're better than doing nothing. Usually, we would use probably 100 milligrams in most patients. If it's a very thin person, then we may go a little bit lighter with just 50 milligrams. But you're trying to achieve 2 or at most 3 eggs ovulating. The higher the dose of medication, you start getting into more anti-estrogenic effects, so it doesn't necessarily improve things. But quick answer to the question is 100 milligrams, which are 2 tablets a day for 5 days. Lifestyle question, very good question. What can you do lifestyle-wise to maximize sperm and egg quality? On the sperm side, the issue here is to not be doing activities that toast up the family jewels. If you're doing a lot of, if you're a roofer and you're wearing heavy jeans in the middle of the summer in Miami, Florida, it's probably not the best thing in the world. If you're a bike rider and you're bicycling you're probably better off wearing a pair of biking pants that gives really good aeration rather than really tight spandex that may just heat up the family jewels more than you like. You want to stay away from hot tubs and steam baths and a lot of alcohol to try and, certainly alcohol use should be minimized. Marijuana use should be discontinued. And just eating healthy and timing. If you have 2 or 3 days of abstinence prior to giving us a sample or prior to the time of ovulation, that should give us the best results. On the female side, the multivitamin is a good idea. Healthy lifestyle, good diet, also good. Activity, most of the time normal activity is fine unless you're a marathon runner and it's interfering with your ability to ovulate and have a regular cycle. So common sense goes a long way in this. Question as far as can with PGTA without ICSI and IVF cycle, we don't really recommend that for a couple of reasons. One, even with normal sperm and normal eggs, there's going to be a small percentage of people that fail fertilization, and there really, in this situation, there's really no downside to ICSI. If we don't ICSI, if we go back to when we didn't ICSI everybody and it was failed or poor fertilization, first question you're going to ask is how come we didn't ICSI the egg? So it doesn't do any harm and it maximizes the fertilization process. The second component of that is by taking just a single egg and injecting it into a single sperm, it minimizes the risk of any contamination from the biopsy from sperm that is swimming in a culture media, so that the biopsy itself, the PGT, is much more accurate. So we do not recommend, in our center at least, to do PGT for aneuploidy without ICSI being performed. Question on 38, what procedure do we recommend for the best outcome? The best procedure for the best outcome depends on what we're treating. If you're not ovulating, the best procedure to start with is ovulation induction with a fertility drug. If you don't get pregnant within a reasonable amount of time, then you can move on to something more successful and more direct. With any cause of infertility, the most successful thing we're going to do is IVF. It has the best success rate, and the reason is, if you remember that to get pregnant, you have to ovulate. You have to have sex at the right time of the cycle. The sperm have to swim up through the cervix, up into the uterus in the tube, fertilize the egg in the tube. So the tube has to figure out where the egg is, get the egg. The egg is then transported by the tube to the middle of the tube. The sperm have to swim all the way up through the uterus into the tube, find the egg, and penetrate the egg and fertilize it. Once that takes place, the tube has to transport on its own with these little fine ciliary cells to transport the embryo back to the uterus where it has to implant. And then we see if it worked or not. So any defect in the tube finding the egg being transported to the middle of the tube, the sperm finding the egg, the sperm fertilizing the egg, the tube failing to transport the embryo, all those things are bypassed with IVF. So the only thing left with IVF is will the embryo stick or not, and having the advantage of doing genetic testing for aneuploidy to make sure the embryo is okay. At least we know we're putting a normal embryo into a normal uterus at the right time of the cycle, and that's going to give us the best outcome. If you have a normal embryo that's genetically been tested and we put it into a normal uterus, whether you're 23 or 43, the success rate is going to be 50 to 60% with a 10% miscarriage rate with one embryo being transferred. The problem in patients that are older, you don't often get that one normal embryo to put back. Question of how much progesterone and oil to use. Can you have too much progesterone? It doesn't seem to be. It's the timing of the progesterone and how it is, and the timing of the embryo transfer. So if you have an excess dose of progesterone, more than we normally would give prior to embryo transfer, that may affect the implantation bed of the embryo. But there's a big variation in blood tests, and depending on how the progesterone is given, and it's more of what effect it's having on the lining of the uterus. IM progesterone is absorbed better than transvaginal progesterone, so blood levels when you use it vaginally don't quite work as well. Usually there's not a problem with too much progesterone. Question of whether progesterone and estrogen out of range can cause infertility. The progesterone level in the second half of the cycle, if done as a random blood test on about a week after ovulation, a normal value is in the 10 to 20 range. And these hormones are pulsatile. So if you measure progesterone every half hour for 4 hours, you're going to get 4 different values. But if you get a single value in the 15 range, then that correlates with an endometrium that's responding normally. Same thing in the middle of the cycle, your estradiol levels, depending on what's going on a natural cycle, it'll vary from 150 to 300. On a femara cycle, it could be half that. On a clomid cycle, it's usually a little higher. So the actual numbers don't matter. It's the biological effect of these hormones are what really counts. When we're measuring hormones post-implantation, we're just making sure that patients are getting the correct amount of hormones. Question: 40-year-old, 2 failed embryo transfers, 1 failed retrieval, 1 embryo left. If you're trying to retransfer the 1 embryo or get more eggs, if you're only trying to have 1 baby, then you might as well transfer the embryo because it's either going to work or not work. If you are thinking that, hey, I want to have more than 1 child from what I might have already, whether it's 1 or 2 or nothing, then in any patient, even if there hasn't been failed cycles of treatment, if someone's 38, 39, or 40, and you're doing an IVF cycle, and let's say you want to have 2 kids, and there's only 1 embryo, if we get you pregnant with that 1 embryo, it's going to be 9 months till you deliver the child, another 6 months until you're ready to be put back on fertility drugs. So someone who's 40 is now 42, and your potential of producing good eggs that are going to result in normal embryos is just going to go down further the older you get. So in a case here, it's a matter of what your goal is. If the goal is I just want 1 child, then you might as well try the embryo that you got, and if it doesn't work, then you can go back to another fresh cycle. But if my goal is, hey, I'm 40, I want 2 more kids, and I only got 1 embryo, then you're much better off getting some more embryos now and stockpiling them so that you have a good chance that one of them is going to result in a healthy ongoing pregnancy. What do you do if your tubes are blocked? If your tubes are blocked, you've only got 2 options. One is to unblock them surgically, and the other is to do in vitro fertilization. IVF is usually the better approach in the end. The only caveat is that if the tubes are blocked at the end of the tubes and the tube is dilated so that you have what's called a hydrosalpinx, where the tubes look like little water balloons on ultrasound or hysterosalpingogram. If you have dilated tubes that are collecting fluid, that fluid can leak back into the uterus and prevent an embryo from sticking. So if you have dilated tubes, often the recommendation is going to be to remove those tubes rather than try and fix them and focus on IVF as a way to get pregnant. IVF is going to have a much better chance of getting you pregnant than fixing the tubes and waiting to see what happens and then ending up coming back and having to remove them and then do IVF in the long run. If the tubes are blocked at the entrance where the tube and the uterus meet, that you can try cannulating that surgically, and the tubes may stay open for a short period of time, or they may not. It depends what's plugging the tube in the first place. If the tube is plugged with some mucus and stuff, you can dislodge it. It's no different than you've got a toilet that someone's got toilet paper stuck in, nothing goes down, you snake the toilet and now it works. But if the tube is scarred closed, then there's nothing you're going to be able to do. You can't snake that pipe with a wire. You're not going to be able to snake that tube with a very fine catheter in the operating room. So with most tubal blockage, the best approach is in vitro fertilization, just to bypass it. And certainly with tubal ligation, IVF is certainly advantageous than doing surgery to put tubes back together. When would we transfer more than one embryo? Our best practice is to transfer a single embryo, particularly if that embryo has undergone pre-implantation genetic testing for aneuploidy. The pregnancy rates are very good with that. In someone who's failed multiple cycles, we may consider putting two back. In a patient that's absolutely adamant that wants two embryos going in for whatever reason, we're happy to consider that request, although we usually will counsel you that just because you put two back doesn't mean you're going to get two. Even with two embryos transferred, the multiple pregnancy rate is only 40%. So most of the time we get the best outcome, the safest pregnancy, by transferring one embryo at a time. If they're non-biopsied embryos, then one can consider putting more than two back and more than one back. If you're over 35 and they're non-biopsied embryos, then we can consider putting two back, and if you're over 40, we put up to three back if they're non-biopsied embryos. Biopsied embryos, one is all you really need, but we can do two. Can we achieve a multiple pregnancy? You can increase the likelihood of a multiple pregnancy by doing IVF and putting two embryos in, and the multiple pregnancy rate will go from 2% to 40%, but it doesn't guarantee that both embryos are going to stick or continue to develop. Question of cytomegalovirus with using Valtrex. Valtrex is good for herpes. In all honesty, I'd have to look up the literature on whether CMV makes a difference. And if your husband is CMV positive, if he's IgM negative, then the risk of infection is virtually nil. If he's IgM positive, then there may be recent infection, and he should be evaluated for that. I don't see the Valtrex for CMV, particularly if he's IgM negative. It could be IgG positive. That's not a problem. I'm not aware of CMV causing any issues with implantation. The last question for the afternoon is, how long is the process from doing tests to starting an actual IVF cycle? Assuming that nothing's been done ahead of time and patients coming in, I've been trying to get pregnant and I need IVF, or I want IVF, or my partner's sperm is lousy. It takes 1 month to get all the preliminary testing done, and then the next month we can have you in treatment. So if you've had the tests done before, we can usually get you started within a month, at most 2, and then the outside limits would be 3. But most of the time, 2 months is all we need from the time you see us to the time we can get you started. Our program runs continuously with the exception of the Christmas, New Year shutdown. A lot of IVF programs do what they call batching, where they save up all their patients and then do a whole lot of patients at one time. We have 3 full-time embryologists with many, many years experience. We're able to give individualized care, and as a result of having that full-time staffing in the lab, it allows us to treat patients on a patient's schedule, not on ours, so that we can optimize your treatment and get you through the system in a timely manner. Question about eggs getting eggs and having not fertilized. The question is, why didn't they fertilize? Was it a sperm problem? Was it an egg problem? Was it a combination of the two? Was it something unknown? Were the eggs good quality or bad quality? That you need to discuss with your individual physician. But it's rare to have good eggs that don't fertilize at all, as long as we're using sperm that are alive. If we're getting eggs that are very poor in quality, then we see lower fertilization percentages, and certainly you can have a failure. There are rare cases of failure of eggs to fertilize despite good eggs and good sperm, but they're very, very remote. What's the maximum dose of medications that we use? We try and select a dose that's specific for the individual so that we get the best possible response. Ideally, we'd like to get 15 or 20 eggs out of everybody. The problem is that's, despite us wanting to do that, it's not realistic that that's going to happen, particularly in patients that have diminished ovarian reserve and don't respond well to fertility drugs. So the dose varies. On the low end, it's usually about 225 units a dose total. We use a blend of Menopur and Gonal-f, so it's 2/3 Gonal-f, 1/3 Menopur in general. In patients that have a lot of ovarian resistance, who are older, and we use higher doses of drugs, the maximum dose is between a total of 450 and 600 units. And when you're on the maximum dose, you're on half Menopur and half Gonal-f. What does priming of estrogen do? And I'll make this the last question. Priming with estrogen doesn't seem to suppress as much as birth control pills do, but individual patients can have individual responses. Some do better with one than the other, and sometimes it's a trial and error. But in general, there's less suppression with the estrogen. The estrogen is thought to do a couple things. One, if your FSH is a little elevated, it may help suppress that and free up receptors. So it's trying, in essence, to make the ovary a little more sensitive to the fertility drugs in patients that have resistance to it. And so it may be beneficial in patients with diminished ovarian reserve, and it seems to be less suppressive in general than a birth control pill. So these are all great questions, and please feel free to ask me, ask your individual doctor, discuss with us what your concerns are and why things are working and not working. Sometimes it doesn't seem like, why are we doing this or that? We usually have a pretty good reason for our insanity, so to speak, and just ask us, and we're happy to answer your questions so that you understand what we're doing, why we're doing it. Our goal is the same. We're on the same team. We got the same desires. We want to get you pregnant as quickly as possible in a safe manner and help you have a nice, healthy baby and enjoy the joys of parenthood that go along with that. So thanks for tuning in this afternoon, and wish everybody a safe and healthy Monday. Have a good day, guys.